530.21 non-traumatic shock. In non-traumatic shock, you're going to want to start out like everything else with your ABCs. Make sure their airway is patent and open and breathing. Also take their lung sounds. Really also take their lung sounds in this one. You want to make sure that they're not already having wet lung sounds like a CHF patient, and you're not going to make their breathing worse. For circulation, you're probably going to get a slower cap refill because they're in shock, and their skin signs might be kind of crummy. They'll be probably pale, full, and diaphoretic. A big thing for non-traumatic shock is trying to figure out the origin. So is it esophageal varices or is it cardiac in nature? If you believe it is cardiac in nature, you can do a 12 lead on this patient. You're going to want to get bilateral 18 gauges on this patient, or a large bore IV if you can, and run fluids. If you are coming from a place like Mendota, or if you're coming from a table, you can give an epi-drip with base hospital orders. You can do 1 to 10,000, 1 milligram of epi in a 250 bag. If this patient is cardiac in nature, you do have to make sure you are going to the correct hospital. You can't bypass, you can bypass Clovis, for example, if you're coming down from table to go to St. Agnes if it is a cardiac issue. This policy is pretty straightforward and pretty simple. Just make sure you don't overload your patient with fluid and try and keep them baseline. With the epi-drip, you're going to want to maintain a systolic of 100. Policy 530.17, airway obstruction. So for a patient who has an airway obstruction, is conscious and kind of moving around and is not cyanotic, you're going to want to encourage the patient to cough. You're going to want to encourage them to try and spit, and just try and move that obstruction out by themselves. It will be uncomfortable, and the patient might be a little panicky. Just if they're able to move some air, just try and keep them calm. Make sure to get vitals quickly. Make sure to get an O2 stat pretty quickly, because you want to see if they are becoming hypoxic and that airway is not patent enough to where you do have to intervene. If this patient starts to become unresponsive, you're going to want to start doing a Heimlich maneuver, the J, and keep Heimliching, and you try and encourage the patient to cough as well. You're going to want to do a stat transport and try and get a saline lock on this patient, as well as maybe consider administering oxygen at this point. If the patient becomes unresponsive, you're going to want to visualize the airway. If you see the obstruction, try and use a finger sweep to clear the obstruction. If you cannot clear the obstruction, then you're going to want to go over and get your laryngoscope. As well as some McGill forceps. You're going to want to visualize the airway, attempt to visualize the obstruction, and remove the instruction. Do not persist at this maneuver for more than 1 minute. And continue to bag this patient. If you still cannot remove the obstruction, then you can move on to chest compressions. You're going to want to do a stat transport at this time. Then if the airway is still persistent, is still not patent, and you're unable to move the obstruction, you can call in for orders to do a TTIJ on this patient. Then you can use a jet device to ventilate the patient if you have a successful TTIJ. It will be in the Heimlich kit, which is located right in here. This maneuver is only for patients who are 12 years and older. Airway obstruction in kids is also pretty common. Kids like to put in Legos in their mouth, put in toys in their mouth, or they'll literally bite off more than they can chew. For pediatrics, you're going to want to be very, very controlling of that scene, because the parents are going to be distraught, family members are going to be distraught, especially when a kid's choking. For kids, you're going to want to do 5 abdominal thrusts followed by 5 back slaps to try and dislodge that obstruction. If that doesn't work and you need to start taking more deeper measures, you're going to want to visualize the airway like in the other protocol for no more than a minute. If you do need to use the jet, it's not indicated for kids under the age of 12, so you're going to want to just bag them instead. For another common airway obstruction that you may find in kids is croup or epiglottitis. This is more pathophysiological. You're going to look at more sickness than biting off more you can chew. So in this one, you're going to think about medications such as nebulized epi or albuterol treatment. Another good treatment for this is cold humidified air and having them lean forward. Their airway might be obstructed with also saliva. They will be drooling a lot. You can suction out their mouth to just try and keep that airway clear as you can and give that treatment. You can use blow-by pediatric non-rebreather to administer this treatment if you need to. But it should open their airway, and that stridor and seal bark cough will go away. If you hear that seal bark cough and stridor when you walk in, you'll kind of get the hint that their airway is probably closed off. You just need to make sure that their pulse ox is above 93 now to know that they're not hypoxic. This will also be a stat transport where you're going to want to get an IV as well. Policy 530.24, burns. For burns, you're going to start, like everything else, with your ABCs. It is important when you're assessing the airway to look for soot around the nares and the mouth. That could indicate that they have a burn in their throat. You're also going to want to have them open their mouth or open their mouth for them if they're unconscious and visualize the airway. Look for any soot or swelling in the airway. That could indicate an imminent airway compromise or an already airway compromise. If you do see soot around them in the throat and they're moving air fine, be very wary of that and be prepared to intervene if you have to. For breathing, you're going to want to also take the lung sounds, and it's also very important to also take the neck, because you can hear stridor, and that also will indicate that an airway compromise may be imminent. For the burn itself, if it's greater than 15%, you're going to want to use a dry sterile dressing, such as the burn towel. But if it's less than 15%, you can use it moist sterile dressing. For burns, you're also going to want to get IVs. You're going to want preferably a large bore. You can go through burn tissue to get the IV. It's going to be painful, but you can get pain meds. For pain meds, you're going to want to use fentanyl up to 100 micrograms. You can repeat the dose every 5 minutes, not 100 micrograms, up to 100 micrograms. You can give fentanyl if their systolic BP is greater than 100. There is no other trauma, so if they jumped out of a burning building and have burns, you can't give fentanyl because of the other trauma, or that they don't have altered mental status. For kids, it's 1 mic per kilogram. For destination, you are try to go to the burn center. You can, if they prefer St. Agnes or Clovis, you can't take them there, but you can surpass them per protocol if they have circumferential burns. If there are second or third degree burns greater than 10% of their body, or if they have second or third degree burns to their hands, feet, neck, face, or major frontal torso burns. You're going to want to start them off on 6 liters if they're minor burns, and move up to 15 if they're major burns. The big thing is getting their airway under control and getting fentanyl if you can on board, because burns are very painful, and that's going to increase their heart rate, could put them in SVT. So just kind of managing that pain management is going to be your big deal. Most transport times are in Fresno are pretty quick, so you're going to want to get fluid on board pretty quick and that pain management pretty quick. Burns continue. Electrical burns, even though uncommon, still do happen. For electrical burns, you're going to want to understand what kind of voltage the burn occurred with. For AC, for example, you might find the patient in VFib. For DC, you're going to find him in asystole. So kind of when you put the monitor on the patient and see the rhythm, you can kind of get a guess of what voltage caused the patient to go down. You are also going to want to know that voltages over 120 are going to be an automatic burn center criteria. You can take them straight there and bypass hospitals. For chemical burns, you're going to want to irrigate the affected area with water, knowing the chemical does not act with water. Usually with most places where you're going to find chemical burns, they'll have the hazmat book where you can kind of identify what caused the burn, and they'll be able to follow that protocol a little bit easier. For burns over 10%, you're going to want to go to the trauma center. For chemical burns over 10%, you're going to want to go to the trauma center. When identifying what percentage of the body is burned, you're going to want to use the rule of 9s. So it's going to be 9 for each arm, 18 for the torso, 9 for the head, 18 for each leg, and then 1 for the perineum. For fluid resuscitation, you have a bag of LR here. you can see. For your fluid resuscitation, for transports less than 30 minutes, you're going to do 150 milliliters an hour in standard tubing. For kids, you're going to want to use 10 cc's per kilogram per hour. When dealing with kids, you're going to want to use the Volleytrol located in the unit to help